Yeah, thank you. Thank you for the invitation, and thank you, Marko. Marko is now very popular in Finland because Marko is the captain of the Finnish ice hockey team. Marko Anttila, Mörkö. So I'm going to talk about health and mainly on reproductive health because every ox driver is talking about oxes. And that's where I have worked most. But one could talk of many aspects of health, and each of them has a lot to do with environmental pollutants. And I've realized during today in this meeting really that the medical society and medical doctors are way behind in thinking of the environmental issues than you guys here and this society. And you may realize that also in my conclusions that now I feel very naive to present to you, but when I'm presenting the same conclusions to my medical colleagues, there is always skepticism and they think this is not possible. These are my disclosures. I have had some lecture honoraria, not too many. And these small pictures tell about one aspect that has been much in discussion in Finland and in other places in the world too. These are declining fertility rates. And you can't see any individual lines there, but you realize that they are going down all over the world. And you may see there this dashed line, that's the replacement level, which is 2.1 children per reproductive age woman. In Europe, we have been a long time below that level, but also many countries in Asia are below that level. All countries in North America are now below that. South America is approaching it, and the only continent that is still above it is Africa. And you all know what does this mean for our future, and we felt it during the Europarlament election that some people want that these people from Africa shouldn't come to Europe. But if they don't come, we will be extinct pretty soon. Well, today I got the statistics of the Finnish birth rate this year for the first 3 months, and it was 1,000 less than last year. You might think that, well, that doesn't matter a lot. But we had only 47,000 children born last year. The previous year it was 55,000, and it used to be for long 60,000. The baby boom generation that my oldest brother belonged to was more than 100,000 per year. It was in the after the Second World War and until early 50s. In European Union, the blue line, United States and Japan, total fertility rate is below 2.1. In Finland, it was last year 1.4, the same rate as in Mediterranean countries and in Japan. And in the US, the birth rate has gone down 11 years now, 11 consecutive years, and there the fertility rate is now 1.7, much lower than in this old picture. What does that matter? The Finnish rate is here 1.4, here is 1.7, the current US stage. So if we start from here and look at the first generation, this is the number of people for the first generation, second and third generation. For the Well, I have to calculate now time when my one and only granddaughter has her granddaughter. Then there would be about 1/4 of the population, of the current population of Finland left. It does matter. Well, I'll come back to this, that what does this to do with environmental pollution, if anything? Of course, the main reason why the birth rate goes down is the education of women. And it's a good thing when all women in the world are well educated, then it means it has direct correlation to decline in birth rate. But there is limit to that also, and the limits come here. This is not only education and societal reasons, there are also biological reasons for declining fertility. Now, in many European countries, like in Finland, 5% of children are born with assisted reproduction. In Denmark, it's close to 10% of children are born with assisted reproduction. And it doesn't always function. It functions only in 1/3 to maximally half of the cases. So one thing affecting our fertility, of course, is how much sperm we have. And the sperm counts have declined. This is from the unselected Western population. And this from the Hamish Levine's meta-analysis from Human Reproduction Update. If we look at the European countries and Japan, and young men whose fertility during the study was unknown, so they come from the general population, we can see that in all countries the median sperm concentration varies between 40 and 60 million per ml. You might think that this is a good figure, but I come later and show that actually it's there, it's on the brink of problems. Of course, there are many other things that are going wrong, and many endocrine-related diseases, their incidence is increasing. Obesity, one area, of course, then you can always say that, okay, it's only diet and lack of exercise. But if you have treated epileptic patients with sodium valproate, you know that he or she, most of the patients will start to gain weight very fast after you start sodium valproate. The same with many neuroleptics, which is a big problem in psychiatric care, that the patients gain weight because they are given chemicals that influence their obesity. Now, the one big problem is that we don't know which of the chemicals that we are exposed to contribute to our appetite and satiety and to our obesity epidemic, in addition to our poor diet and lack of exercise. Breast cancer, big problem, 10% of women have that. But then one of the steepest increase in the cancer incidences is testis cancer, which is a cancer of young men. It occurs between, usually the patients are 20 to 45 years old. And in the old age, it's coming rare. This is from the Northern Europe, and there are big differences between the countries. Here are the Baltic countries, Finland, and the top countries, Norway and Denmark, close to it. Interestingly, in Denmark, it seems like it has leveled off, but in all other countries, it keeps going up. and the change is really big. In Finland, if I would give relative risk 1 to my grandfather, who was born in 1890. My father was born in 1925. His risk was double to my grandfather. I was born in 1958. My risk doubled from my father's risk. My children were born in 4 boys in 1980s. Their risk has doubled from my risk. So this goes really fast up, and not only in Northern Europe, but also in Asia, Eastern, Southern, and Western Europe, and in the Americas. There are, of course, genetic susceptibility that is playing a role also, because that we know from the US population very well, that here are the Caucasian or European population in USA, and this is the African population of USA. But in both population groups, it goes up. How does this cancer come about? We know that it has a developmental origin where the primordial germ cell, which is in the fetal testis, does not develop normally towards this route that gives spermatogonia, that are the stem cell population of sperm production, which starts at puberty, meiosis, and sperm production. When these fetal cells somehow gets into wrong environment or gets wrong environmental signals from the somatic cells that surround them, Sertoli cells and Leydig cells, it forms these germ cell neoplasia in situ cells that are quietly sitting there in boys' testes. When the puberty hits with its hormones, it starts to proliferate, forming seminoma, or if it's a little more primitive, it has stem cell properties and it produces all kinds of non-seminomas, like embryonal carcinoma. Epidemiology of testis cancer is very clear because it occurs in young men, and the men die if they are not treated. But if they are treated, 95% of them are cured. So they are all very well registered, at least in Europe and in the United States. One could say that, like the Nordic cancer registries for testicular cancer are 100% reliable. Sperm quality and testis cancer have something to do together because they both have to do with the disturbed testicular somatic cell function that leads to impaired germ cell differentiation and production. And the same somatic cells, and especially Leydig cells, produce testosterone during fetal development, and that's the hormone that makes a man. If there is no testosterone, the fetus will develop to a little girl and will grow as a girl. If the Leydig cells produce too little androgen, then the newborn boy may have many problems, may have hypospadias, where the urinary tract is misformed, so that the urethra is split below the penis, and the boy has to pee sitting, not standing, because the urine doesn't come from the tip of the penis, but is sort of dripping along the shaft. Another problem is cryptorchidism, which means that the testes don't descend to the scrotum at the end of the pregnancy, but remain hidden. And we know that if they stay there, it's causing infertility. A readout of this androgen action is anogenital distance. That is the distance from the anus to genitalia, which is 2 times longer in boys than in girls. So if that is shortened, that means that the boy has had problems in having enough testosterone during development. And all these then share the risk factors here. And we know that there are many genetic defects that cause all of these problems, like androgen receptor polymorphisms and androgen receptor mutations. And depending whether the androgen receptor is functioning or not, if it's a complete androgen insensitivity, the newborn baby is a girl, and then she doesn't have too much problems other than that she can't reproduce, but she's a sort of normal-looking girl and will grow as a woman. But if there is a partial androgen insensitivity, then the newborn boy has all these problems and a very increased risk of testicular cancer. So we know that also environmental pollutants that block androgen action or cause androgen insufficiency by inhibiting androgen production can cause the very same problems. So we set up 20 years ago, or more than 20 years ago, in Copenhagen and in Turku to study how common these problems are and what could be behind them, and recruited 5,000 families that got 2,500 boys, whom we then studied with questionnaire during pregnancy, trying to find out their exposures and medical background, and then we collected a lot of samples at birth and after birth, and further on studied this. The background was this big difference in the testis cancer incidence between Denmark and Finland, and we wanted to see that are there other things that are different, and indeed there was. The cryptorchidism in Denmark was 3-fold more common than in Finland, and hypospadias similarly much more common in Denmark than in Finland. On top of that, there was this interesting difference in the sperm concentrations. We first studied fertile men, which were actually the fathers of these children, who were studied during the pregnancy. And the Finnish fathers had much higher sperm concentration than the Danish father. But this is, of course, a very selected group of men because they were fertile, and we wanted to also study unselected population, and to do that we recruited 19-year-old young men, and we saw that there was also a difference, and interestingly a big difference between this unselected and selected population, which is sort of understandable, but at least to me that the difference is so big was a little surprising. We followed these boys for 10 years and studied them 4 times, and their sperm production doesn't increase. They stay on this level. Of course, the question was then that what's the difference there? And we measured a lot of chemicals in the breast milk and in placenta, and as much as we were given money to do these exposure measurements. And this is just the one example of the difference between Finns and Danes, that our exposure to different dioxin congeners was distinct, which was peculiar, and we don't know why is this. And more recently, Jean-Paul Antignac repeated with a new set of samples this analysis in France and had the French breast milk samples that originated from 10 years later. So you can appreciate that there the levels were much lower than in these that came from the turn of the millennium. The French profile is similar to Danish, and Finns are here. There were many other chemicals that we were differently exposed, and from the persistent organic pollutants, in every case, Danes had higher concentrations than the Finns. But we don't know whether this would be the cause for these reproductive problems. But from dioxins, we have some data from Seveso accident, from Paolo Moccarelli's now already old studies, but they showed that those men who were as children exposed to high dioxin level in Seveso and who were breastfed, they had the lowest sperm concentration. Those who were formula fed and had only this fetal exposure but not postnatal exposure had much better, and the best was the control group, breastfed control group here. So for sperm quality, not only fetal exposure but also this postnatal exposure that occurs in very active reproductive developmental phase of boys, which is called mini-puberty, that occurs during the first 3 to 6 months after birth, is important, because during that time period, these Sertoli cells that take care of spermatogenesis proliferate very fast. And so it's not very good to get high exposure in that period. We analyzed adipose tissue samples from the boys that underwent orchidopexy. That's the surgery that needs to be done to bring the testis down to scrotum to retain fertility in the boys. So it needs surgical operation. So during those surgical operations, fat tissue was taken and we measured dioxins there. And first of all, this shows that the longer the boy had been breastfed, the higher was the dioxin levels, also PCP levels. There is a very direct correlation. So the mothers download these persistent organic pollutants very effectively to their firstborn children, and then the more children you have, the less is left in mother, which is good for mother, but maybe not good for the children. And here we see, if we take into consideration this breastfeeding time, the controls have always lower levels than the cryptokit cases. That's not a big difference, but it could have something to do with dioxins, or it might be a bystander effect for another persistent compound that is delivered to the boy in the same way as dioxins and PCPs. We don't know that. More recent, another study from Russia with Rushhauser's work, where here the TCD concentration in boys at the peripubertal time was divided into quartiles. And in the highest quartile, the boys a few years later had the lowest sperm concentration. From the animal work, we know that dioxins cause a decline in sperm counts. Well, this is all about persistent organic pollutants, and you know better than I do that there are all these others. And if we think of POP chemicals, then like DDE levels have really gone down. This is from Japan and from Sweden. But still, in our material, when we compared the cryptorchid and normal boys and these old pesticide residues that were still in these boys like 20 years after these chemicals have been banned. So they go from mother to child, and the girls take care that it's carried to the 6th generation. Still, DDE is top on the list, and if one permutates all these together, there is a difference between the groups, so that the cryptorchid boys were more exposed than the normal boys. Again, very small difference, and maybe just a bystander effect, we don't know. But then there are other chemicals that increase or fluctuate. This is the flame retardants. And we measured flame retardants in breast milk too, and their level is higher in cryptorchid boys than in controls. And the one thing that where there is pretty clear-cut effect on fetal exposure to semen quality is whether mother is smoking or not. If the mother is smoking during pregnancy, the boys have 20 to 30% less sperm production as adults. Smoking of a young man himself has very little effect, if any. So the doctors always say that stop smoking and stop drinking, but I've been saying that it doesn't help sperm production. That's too late. The thing that you can do with stopping smoking is that you remain your erectile capacity a little longer, so that you need Viagra or other potency medication a few years later than if you stop smoking. Unfortunately, sperm concentration also in Finnish men is declining, and in rather short time period. These are cohorts from the 1980s, and now I come to what does it matter? This is from Jens Peter Bondes and Nils Kakkebäck's paper from Lancet, where they analyzed the first pregnancy planners, time to pregnancy time, and looked at the start of the study, sperm concentration of these young men. And the probability of pregnancy per menstrual cycle, when there is no contraception used and there are, they try to get children. When you go below 40, or it's somewhere here around 50, then the probability goes rapidly down. And you may still remember the slide I showed where we are in Europe and actually all over the world. The young men, the median sperm concentrations are right here. So half of the young men are on this slope. We can look at in the other way also, from the same data that, of course, if you have time, here is if you have 50 million, then in 2 years, almost all will get pregnancy. But when you go down in sperm concentration, then the probability goes down. And when you have the other side of this, which is the female partner, whose fertility goes steeply down after 37, or even after 30 it goes down, but steeply down after 37, then the mean age of the first baby in Finland now is 29 plus something years. And I guess in Europe it's around 30 or above 30. You may get one child, but then you are already 35 when you try the second one perhaps. And then if you need to wait for 2 years, then it really is too late. In Finnish men, those with more than 40 million per ml, that proportion has gone down, and the latest results from Denmark and Finland show that if one looks at men with high semen quality that fulfills all the criteria of the WHO for good semen quality, there is only about 20% of those men. These are the effects of the experimental animals when they are exposed to antiandrogens. I already talked about this when describing the human findings. And also there are many Danish and studies also from NIEHS and from EPA laboratories from the United States showing that the effects of antiandrogens are additive. So in the studies of Ulla Hass and co-workers in Denmark has shown that when one puts these fungicides, vinclozolin and prosimidone and prochloras pesticide and a phthalate together in doses that are below their no observed adverse effect levels, in single exposures there is no effect, but together there is a 100% effect. And that's where we are. We are with this mixture exposures all the time. This is from my students' work that is under revision from reproductive toxicology. One slide that just shows the fetal testis exposed to perfluorooctanoate. And PFOA very effectively is inhibiting HCG stimulated testosterone production. Well, we've heard many talks about here how common these compounds are all over the world. This is an old picture from the WHO review. And so I was very happy this afternoon to listen to the talks that how we try to get rid of these compounds. Because these not only phthalates, but many of these perfluorinated compounds, also many polyprominated compounds have an anti-androgenic effect. Either they decrease testosterone or block androgen receptor. Some do both. And not only these, but also dioxins seem to sort of affect to the same funnel that produces all the problems down here, which is a poor semen quality, cryptorchidism, hypospadias, and testicular tumors. So what to do? So this I thought that this is sort of naive to show to you, but I show it anyways. Because when I show this to my colleagues, it's not at all clear to them. Although I think it's sort of self-evident what we should do. There are a few publications that are out of print, but one can get from the WHO Center of Children's Environmental Health pages, and from there one can get also this WHO-UNEP report. Many of the authors are here too, and then the more recent is the Endocrine Society. That's also open online in endocrine reviews. So as a summary, I would say that the problems have increased and they often have developmental origin. And it has to do also with endocrine disrupting chemicals, and our burden is increasing. Luckily, for some exposures, it's also declining. But we have still really a lot of lack of knowledge here and still inadequate testing. And I would like to thank my colleagues in Turku, especially Helena Virtanen and now Vivat Rodbrasert, a very good student from Thailand who's been working. And of course the people from Copenhagen, Katarina Main and Nils Skakkebæk. Nils Skakkebæk has been a real primus motor for all these studies, and I thank you for your attention.
So thank you very much, Jorma. We have time for questions.
I'm Sari Kauppi from Finnish Environment Institute, and I would like to know how much do you think the military service that most of the young men go through in Finland, how much does that has an impact on sperm concentration, because nowadays they are using different waterproof coatings and antibacterial materials in clothes and other textiles?
I didn't talk much about how the sperm production capacity is sort of created, but it's really developmentally set so that after puberty it's pretty stable. Of course one can do harm and you can bring it down, but then you can't bring it up. But this sort of acute toxicity, then one has to have pretty harsh effect to see that. And so I don't think that in the military service these exposures would be so high that it would have direct effects. The effects are more of a developmental nature, where the system is very sensitive for hormonal changes.
Yes, thank you. I'm curious as to how you reconcile the statement that the anti-androgenic effects are additive with the published information that there are thousands of chemicals on the market in the EU, and that as many as 8% of them are reported to be or speculated to be anti-androgenic, and that exposure to just 15 of those in mixture is reportedly putting 5% of the population over the level that would cause male reproductive tract malformation. So if you do the math and you add the exposure to the other thousands of chemicals, it's an inescapable conclusion that no male child could be born in the EU without male reproductive tract malformation. So I'm wondering which piece of information is incorrect. Are anti-androgens not all additive, or are there not nearly so many anti-androgenic chemicals on the market in the EU?
According to the all experimental data, they truly are additive, but then the potency of the different chemicals is highly variable, so there are some that have rather weak activity. So then even adding those and low exposure, that together that they don't add up. But we do have a very high percentage of several percent of boys have cryptorchidism as newborns. So it's a very common malformation, and a very high proportion of the population, the sperm concentrations are truly low, and they are lower than they used to be. So and this skyrocketing of the testicular cancer is also of high concern, and if it has anything to do with the anti-androgen effects, then it's pretty bad.
Yeah, I don't think that quite answers the question. But my point is that by the calculations of those who have done the risk assessment, Andreas Kortenkamp's group in particular, that algorithm and that theory predicts that well over 100%, in other words, fully 100% of the population should be experiencing hypospadias, cryptorchidism, because of the additivity, and the methods used are a hazard index type of approach which takes into account the potency of the chemical. And yet the incidence of hypospadias and cryptorchidism is quite, it may have increased or decreased depending on the papers that you read, but at any rate it is not nearly 100%, it's single-digit percentages. So I'm still curious as to how one can reconcile those two concepts.
The last time I heard Andreas Kortenkamp, I had a different understanding on his calculus, that it didn't add up to 100%, vice versa. It was sort of concern, but almost on the other side.
Any more?
Thank you for your presentation. It was really nice. Thibaut Demirbo from Zoetis. Do you have any recommendations towards breastfeeding then, in terms of duration or abstinence of breastfeeding?
Yes, I do. Yeah, I recommend breastfeeding to all children except for those who have some special medication where the medication is not good for the baby. But all women, no matter how exposed they've been to persistent organic pollutants, should breastfeed, because it gives so much benefits compared to the potential risks. Yeah, thanks for that important question.
I'd just like to ask a question about correlation with estrogenic chemicals as well. You looked at anti-androgenics, but we're aware that our diet has changed substantially over the decades, and we're exposed to a lot of low-level estrogenic chemicals, some of them just natural estrogens anyway. And how does that correlate with the malformations and cryptorchidism cancer incidents you've got there?
Yeah, that's the history started with the story of diethylstilbestrol, which is a very strong synthetic estrogen, and where there were randomized double-blind controlled studies of pregnant women eating diethylstilbestrol and their boys had declined sperm concentration, had increased rate of hypospadias and cryptorchidism. So one first thought that maybe it's the estrogens. But then there are quite a lot of studies of other, even synthetic estrogens like estradiol or the contraceptives, and which don't show any association to these malformations. So it really, it might together have a little added effect because it's functioning or influencing to the same direction, but at least not alone. It won't do this.
Okay, and so I think we will stop here, and SETAC has a small gift for you, Jorma. So
thank you.
Thank you again.